না বিজয় মানে মুক্তি, বিজয় মানে দৃপ্ত পায়ে এগিয়ে চলার শক্তি। সবাইকে মহান বিজয়ের প্রাণঢালা অভিনন্দন ও শুভেচ্ছা। So we all know the definition of heart failure. Heart failure is a complex clinical syndrome with symptoms and signs that results from any structural or functional impairment of ventricular filling or ejection of blood. Now, in this topic, we'll examine the utility of echocardiography in the assessment and management of patients with heart failure. So there are some questions. Why we'll do echo in heart failure? So why we'll do echo, whom to do, when to do, what to do, and how to do. So first comes why. We all know that heart failure is classified according to the ejection fraction. These are the heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction, heart failure with reduced ejection fraction, and recovered ejection fraction. So we can differentiate between preserved and non-preserved heart failure. For choosing right time for valve surgery, timing for different device implantation, initiation or discontinuation of chemotherapy, detection of mural LV thrombus in the setting of global or regional systolic dysfunction is a strong indication for anticoagulation. So whom to do? We all know the symptoms that are presentations of heart failure. These are the common symptoms and uncommon symptoms. So careful history and physical examination guides investigation, and first-line imaging is recommended in all patients with suspected heart failure to assess structure and function. So 2022 guidelines for heart failure recommended the same thing. This is the algorithm, similar feature. Now comes when to do. So for the new onset heart failure, we should do echo immediately. After the titration of triple therapy for heart failure with reduced ejection fraction or consideration of ICD or CRT implantation 3 months after the completion of titration of therapy. For stable 1 to 3 yearly, and after significant clinical events, that is after some heart failure hospitalization, that is during hospitalization or within 30 days. And what we will see. So these all are discussed by my previous brilliant speakers. So I'll just go short that what to see. So we all know that we'll see the global LV systolic function, diastolic function, LV structure, RV size and systolic function, then valvular structure and function, and pericardial assessments. And now comes how to do it. So first comes the LV systolic function. So it has been described by my previous speaker. So we'll see the global LV systolic function by ejection fraction, MAPC, EPSS, MPI, 3D, microcell contrast imaging, and then regional wall motion function. So ejection fraction is the magical word. We did it by visual eyeballing method, emoticos, which is obsolete nowadays, and the biplane Simpson method, modified Simpson method. So this is the eyeball and the modified Simpson, we all know that. But the cutoff values for male 52 to 72 and for female 54 to 74. So these are the other modalities that we can see the LV function, that is MAPC, or then it is normal LV function, the MAPC, then the depressed LV function MAPC, and then SVF, TDI, SVF is normal and in depressed LV function. So we all know that how we can assess the regional wall motion abnormalities. So first, a 35-year-old man with a shortness of breath came to us. Echo was done. The LV was dilated and modified Simpson method, it was 31%. And there was moderate eccentric AMR, and see the EPSS is raised. So dilated cardiomyopathy. A 55-year-old lady, status post CBG, swelling of whole body and shortness of breath came to us, and this was the scenario. And there was a global reduction of LV function, and there was severe MR and TR. A 40-year-old male present with anterior MR, shortness of, then after 3 days, he developed shortness of breath, hypertension, bilateral basal crepitation, and there was a systolic murmur. And we have done the echo and found that he had VSR. Posterior MR, having papillary muscle dysfunction and MR. Papillary muscle rupture with severe MR. Then comes LV diastolic function. We all know how we assess the function, and there's a cause, the responsible clinical conditions for heart failure with preserved ejection fraction. And the grades 1, 2, 3, I won't go through that. So grade 1, pseudo-normal, reversible restrictive, then the restrictive pattern. And we also see the L volume index, TR velocity. A 40-year-old male just came to us with chest pain and syncope and shortness of breath. He had asymmetrical septal hypertrophy, and there was SAM present, and there was LVOT gradient, so hypertrophic obstructive cardiomyopathy. A male patient, 56 year, with dyspnea, basal crackles, systolic murmur, and there was bicuspid aortic valve calcified, severe, and his gradient was severe, aortic stenosis. So this is the algorithm for LVF with for diastolic dysfunction. Then comes a right heart assessment. So we all know what are the parameters that can be measured for right heart assessment. Young male, 35 year, came to us. He had history of DVT, developed shortness of breath, pleuritic type of chest pain, RV was dilated, and I think there was McCullen signs, and there was thrombus in the pulmonary artery. So pulmonary embolism. A young lady, chest tightness, shortness of breath, repeated episodes of syncope. On examination, there was a diastolic murmur, and on echo, we have seen that LMXoma. A patient came with sudden chest pain and shortness of breath. On examination, JVP was raised, and bilateral, there was lung bilateral rails, and it shows rupture sinus of Valsalva. IV drug abuser, young patient, fever for 1 month, toxic. He developed chest pain, shortness of breath, and he had puncture marks in both the arms. And on echo, we have found that there was vegetation in both the tricuspid valves and severe TR. So there was a young patient. This was double chamber, right ventricle. Some structural heart disease like mitral stenosis, we all know, thickened mitral valves, and gradient was high, severe MS. Some aortic regurgitation and some mitral regurgitation patient came to us. Some congenital heart diseases like ASD, patient 35-year-old lady with the complaints of shortness of breath, and he was D-shaped LV, and there was severe TR. And on T, we found that there was fenestrated IS, interseptal defect. So some patients, young patients with VSD, young boy with severe pulmonary RRB dilated with severe TR. We did the transesophageal echo. There was no ASD or some peripheral diseases. like a patient, young lady with shortness of breath and hypertension. And we did the echo. It was severe pericardial effusion with features of tamponade. And a young girl came to us with swelling of the abdomen and shortness of breath. So echo was done. There was septal bounce. And the features of constrictive pericarditis that Colonel Parashar has described previously. So IBC dilated. So my take-home message, echo is the imaging modality, a patient with suspected heart failure. As for classify, then find out the etiology, then assess the management and surveillance. It is a readily available and low cost, useful for diagnosis, prognosis, and guiding of therapy of heart failure. But the limitations are inter-observer variability and assumption of geometric shapes are sometimes difficult, and heart rate and load dependency. Thank you.